अभी मैं Facebook पे जा रही हूँ. I'm trying to go on Facebook. So somebody check if we are.
I'm there. Yeah.
Okay, so we are going to start this meeting in a couple of minutes. We are waiting for the audience to join. We've got 3 minutes to go.
Okay, I'm going to leave, all right?
Okay.
And a lot of the structure here, Surendranath kind of briefly told me, but it's more of a Q&A.
Yeah, Neil, yeah, so it's very straightforward. So your audio is slightly not clear. So it's
How about now?
It's breaking up a bit. Yeah, I think we are okay now. So yeah, just in 2 minutes we are going to start. And so Neil, I'm going to be on chat. If there's anything I'll put there. Yeah. And
Okay.
so Neerja ji is here. She's going to start. And yeah, we'll see how it goes. So you are a resident in Texas, yeah?
Mm-hmm. Internal medicine. So I'm a second year.
Yes.
Second year is 75%.
We are on Facebook. Ashwinji, you joined.
So actually, people are excited to see Neil.
Yes,
in
everybody's excited.
the lead
He's
role.
our youngest panelist. So Neerja ji, should we start?
Yes, we'll start. So namaskar once again to everybody who is watching us. Mich आशा कि यम जन ऐसे पतिम 5 सेशन कर तो ऐसे थोड़ा बहुत के इंफॉर्मेशन के डाउट्स के ये जन माइंडस में चासान यम ऐसे कांच ओपनली डिस्कस करें तिमन ऐसे के थोड़ा सा फुट ड्रामास. In this series of COVID health, we are trying to bring in doctors who are actively involved in treatment of this disease, and also who are overall giving us an overall view of what the disease is about, the mayhem that it has caused, and how to address it, whether it's mental, physical. So today we have with us a very young and enterprising doctor from our community, Dr. Neil Ban. And Neil lives in Texas, Houston. I know him for as many years. He's just like a son. Neil currently is undergoing his internal medicine residency at Baylor College of Medicine, and his future interest, I believe, is pulmonology, critical care. He's very much connected to the roots. He does frequent visits to India, and he's connected with public health projects in Gurgaon. He has stayed in Dharamshala also, where he helped with some rural development. It's an NGO that he worked with, and he was there for a while, getting the ground situation and trying to gather some information from there. And besides that, Neil is a very, very hardworking community volunteer, and he has contributed a lot locally in our organization, KOA. He is also very, very resourceful and helpful in bringing youth to the fore, very much connected to the roots. So Neil, welcome. And I am hoping that we are going to get some more information and some more experiences that you've had during this COVID since last year, because you have been very much in touch with such patients. I believe you were in ICU situations also, in emergency situations also. So let me ask you, just give us an overview of your experience from last year when the situation here in US was absolutely very, bad. I would say similar situation that we are currently seeing India in. So give us some kind of, your thoughts about it, what you experienced mentally, physically, with the patients, with the caregivers, and then we can just open up with the question answers and ask.
Yeah, thank you. Thank you so much, Nirjaji. Thanks for the introduction too. I very, very much appreciate that, humbled by that. Can you hear me okay?
Yes. Mm. You're not audible now, Neil. Something happened. Something happened.
Hello?
Yeah, now it's good.
Just disclaimer before I start, this is all in my just personal capacity. So I'm not doing this in affiliation with any of my training program, etc. And I'm not a specialist by any means, still a trainee, but we've had a lot of experience seeing, treating COVID, etc. So I would say, with that said, experience here was very, very rough, especially in the beginning. And I know right now, especially what's going on in India is there. It's hard to compare sometimes, but there was a similar sense of, I know, dread at that time, just because it was so new. And this was around March, April last year, and then going into June, July, when here in where I live, Houston, we had our kind of first big spikes around March, April, and then some more during the summer months, June, July. And I think as a medical trainee here, we work in a lot of the either government hospitals, also some of the private hospitals, but we saw a lot of volume of people, and our ICUs were very full, our emergency departments were full, and I think what we experienced the most was uncertainty about the disease itself, uncertainty about the amount of PPE that we had here, the amount of, in the very beginning, the amount of ventilators, the amount of even ICU beds and staffing. So we also dealt with when the cases increased, and when we started to go through the peak, we dealt with that kind of infrastructure fall through as well. But I will say, I think coming out of that peak, and with a lot of the studies that got published, with a lot of the kind of supply chain side interventions that were done for our PPE, ventilators, staffing, etc., we saw that we were able to get on the treatment side, we were able to get a better picture of what we can expect, what we should expect, and how to treat our patients. So I think now coming into this, we have a lot of people vaccinated. People here in general feel a little calmer. I've seen there's some relaxations now, giving the CDC guidelines on how we can associate with people, with masks, without masks, depending on vaccinations and in what size groups. So we've seen that now, even with the cases that do come in, we have a better grasp on how to treat and kind of how to give people a prognosis and an idea, then also ourselves how to stay safe from the disease.
So I believe, 1 minute, Shafalika, then I'll come to you. You went through COVID too, right?
Yes.
So in this situation where you're already treating or just taking care of those COVID patients, and you yourself got into it, how bad was it? How did you cope up with that? And body, how did that behave?
Yes, I luckily was not bad at all for me. I was working at the time, and I was working the night shifts in one of the ICUs, and we had all our PPE and gear there as well. But I once I started to feel some symptoms, and what clued me in, I was feeling a little tired, fatigued, but I thought that maybe just me on my night shifts. But I one day my coffee was tasting funny, and I make the same coffee every day. So it clued me in, and I knew that I didn't want to knock out everyone else in our ICU because of the important work they were doing. So I got tested, came positive. Then I quarantined at home. Luckily I didn't have much symptoms other than that, mild fatigue, some exercise intolerance. I couldn't go for a run or a workout without feeling fatigued. But after around 10 days, so 10, 12 days of symptoms, they subsided. I never had a fever, and it kind of went away on its own. I did, I was living with a roommate at the time, and he had to get tested as well, came back positive. So we both quarantined, ordered food online, etc., stayed away. And it was after a certain period of time, after my symptoms had gone, then I was able to come back to work with the proper protective gear and PPE.
Okay, yeah, that sounds like some kind of relief to people who experience it, and it's not something you cannot take care of. I guess a lot of panic out there in India right now is about what if I get COVID, and people who already have it and they're going through this, whatever the symptoms are. So there's an uncertainty about it. I think that's more stressful than what you actually get. Not that the disease is any less. It's really, really something very concerning. So Shafalika, would you like to?
So hi Neil. So the question I wanted to ask you, because we are talking in the Indian context, and
Yeah.
you are a resident doctor, and in the early stages of training, and I'm a hospital doctor as well. So when COVID struck in UK, as it has in India, and it was in US as well. So the trainees were the foot soldiers, and I can't imagine any hospital which did not rely on trainees at that time, because you guys were the ones who were in the A&E, were doing night shifts 24/7. The senior doctors, obviously, they have a very important role, but you are really our foot soldiers. So now the situation is the same in India, where the doctors and the nurses, they are at the front line, and having seen the panic and the confusion and the fear it can create in the medical and the nursing community, and you have first-hand information on that, would you have any advice for the doctors and the nurses who are really the analogy of COVID is like you're going into a war, but you don't have the full armament, you don't have the full that machinery to combat it, and it's a very scary situation, and you faced it as a trainee doctor. Would you have any advice for the nurses and the paramedics who are facing this now in India?
Yeah, my heart really goes out to all of them, because I know that feeling for sure. And even everyone from our trainees to even our senior doctors had all put their lives at risk doing this. And we did have a couple of very unfortunate deaths in our professional community as well, including nurses, including senior doctors that have been practicing for a long time, who are, unfortunately passed away working against this. And I think that, that always added on to we had we had a very young trainee here who passed away as well. And that added definitely to the fear, anxiety. It doesn't directly translate our experiences in about a year ago to what everyone is going through in India right now. But I think one of the similar feelings that I can at least empathize with right now is that feeling of uncertainty and that kind of dread feeling. Because during our time, one of the big questions was PPE and having enough equipment there, having enough ventilators. We never had a problem with the issues of oxygen or other or other medicines per se, but we definitely did have that some of the supply side issues with personal protective kits. And I think the way that we coped with it, one was that we had our institutions here and that I trained with, they were very good about keeping us trainees up to date every day on the status, because there's a reality sometimes that we don't have enough. It's not here, and we have to make do with whatever is here, and we have to kind of step up for that call. But to know and to have that transparency that, okay, this is what the status is, this is what I can expect, that it gives you a little bit of agency in that process, was very helpful, because I felt like I even if I had to sacrifice a certain amount of certainty and go into these and go work, I had an idea that there's somebody higher up who's working on resolving a lot of these supply issues, and that eventually, if we're sticking through it, that things will get better. I think
So,
at
so really,
that
your
leadership
advice.
level.
Mhm.
Sorry.
So, I was saying your advice would be to get a team, whether it's a small hospital or a big hospital, get a team sorted so that there is some accountability who's doing what.
Mhm. Yes, yes. And at the leadership level, ensuring that people are being transparent. I think that helps everyone who's working on the front lines so much, to at least, like I said, there's a reality that's there and we have to work through. But if we feel like that we're an active part of that process, or we have access to that information, it's much more empowering and gives you a sense of, um, a little sense of agency that you can continue doing work with this in mind. And then having your own community there to bounce feelings off of, ideas off of, that's always very helpful. So we have having a tight knit, either if it's your other trainees or just family, friends, professional therapists. I think those were very key for that time as well. And will be going forward. A lot of the shock and awe that you've experienced at this point will be helpful to have those support systems going
Yes.
forward to help process, because I know in the midst of it, you don't have time to process what you're seeing, and sometimes I've seen the scenes there, and it's a very horrible. I know it must be a horrible feeling knowing that you're not able to get your patients the treatment that they need, and yet still working around the clock. I can't even imagine, but having those support resources at your side, whether it's family, friends, or professional therapists, I think that would be very helpful.
I mean, one of the things you touched on was shortage. And we are seeing that shortage of supplies in India as well. But that's not just specific to India. We have seen shortages, in UK when we had the first pandemic, there was a lot of shortage of masks, only because we were all caught unawares, isn't it? So by the time people got their act together and started ordering PPE and masks, we'd already lost a few weeks. And tragically, a lot of doctors and medical staff and nurses. So the shortage is not a east or a west thing. It is everywhere, and like you said, you have to be realistic about it and accept it at some point, that there's not going to be enough PPE for everybody. And that's the point of having a team, is who's the person who needs it most, and give the PPE to that person. And then and support each other, because as doctors, we are trained to get people better. That's the aim of coming into medicine. But now, for reasons which are beyond us and beyond our comprehension, sadly lives are being lost. And as trainee, it must have been extremely difficult for you to see that, and then to lose friends and colleagues, which has happened across the world. It's quite pathetic. But then we come to the carers, because in the A&E, in emergency, I mean, we call it A&E here. I think we call it emergency services or whatever,
Yeah.
USA. So that's the front line where people just come in, and for the relatives there is so much panic. And the unique situation is the doctor is in panic as well, and the relatives are in panic as well. So would you have any advice for the relatives who are coming in that state of distress? Because when you have a relative ill, you want to throw everything. You are being a bit selfish there. You want them to have the oxygen, you want them to have the remdesivir or the plasma. And for you at that point in time, your relative is the most important person. But for the doctor, you have to, there's like 20 or maybe 50 other people in the same position. So do you have any advice for the carers who are in this situation?
Yeah, I really feel for them as well, because it's a horrible, horrible feeling. And I know when it's your loved one that you're looking for help with, and you're in that scenario, then they're your patient number one, and they're your priority to get everything. And I understand that has to be there. But I think the advice I could give is that, a lot of these treatments and therapies that are out there, it's used based off of whatever evidence that we have right now. And so we do have a decent body of evidence now, one more than a year into this pandemic, of what works, when it works, how to use it. And I think right now it's hard to translate that immediately to a lay audience and know that these medicines that you hear and these cures and kind of solutions that we've developed so far, they're not it is not a one size fits all and not a throw everything at the kitchen sink kind of scenario. That some of these medications are used in very specific windows. And that's where we have the evidence that, okay, this has some help. So for instance, remdesivir, a lot of those studies showed that the only mortality benefit on the biggest study they did on remdesivir was in mild patients that were requiring oxygen but not advanced respiratory support. So it's a very specific window that they saw any benefit per se. And so when you're thinking about the patients who may need, especially when you have a shortage of remdesivir, then you need to know when to use it the most effectively. And just giving it to everybody is not like an effective use of that medication. There's some people that will be requiring it and see the benefit of it. There's some people that won't. Same thing goes with the convalescent plasma. That also treatment has a very specific kind of niche that can see benefit. And some of the more advanced therapies that are still being studied, like the monoclonal antibodies for the anti-inflammatory markers, for the inflammatory markers, those all also have more niche or kind of end stage applications.
Yeah.
But the basic requirements I know of oxygen therapy, of getting people into a hospital, getting people admitted so that they can be observed, so that if they're requiring oxygen, they can be put on cheap and readily available steroids. I think those definitely need to be met, and
Yes.
that even at this point, I know there are even shortages with those basic necessities, and I know that must be very tough to deal with. So I know people are having to deal with some of these symptoms and issues at home if they're not able to get a bed. And so I think we've been having to adjust our advice based off of that scenario as well, because in general, you wouldn't advise someone to stay at home and take these steroids if they're requiring oxygen. I mean, these people need to be monitored in a hospital for complications closely. They need their oxygen levels need to be their respiratory status needs to be monitored. Once they get steroids, they need to be watched in case for complications, infections, etc. I know in India that's not the case right now for everybody, but you can. I'll kind of wrap this point by saying that there's a whole armamentarium of medications, and right now we have a good body of evidence. Some of these we know very well work for almost everybody. Some of these we know work for very specific populations, and we have to know where to put our energy and what to get. And I think the best people for that are the doctors that are serving there right now, because they know when and how to use these medications. So to put trust in that, it's difficult right now, but I would encourage that.
Absolutely, that is a very important point. Because when patients are being brought to hospital, I think the message here is to trust the doctor, even though it's a very difficult situation. They will do their best. And if there's something they're not able to give you at that particular point in time, there must be some reason. So so the trust in the doctors and the nurses to do their best, because that is an oath all the clinical staff takes, is to do their best whatever the situation. Obviously, shortages of stuff is altogether a different story, but whatever is available, they will give you. And yeah, so on that note, Nidja, you wanted to ask Neil?
I just wanted to ask a question of you, actually, because there's a question about vaccinations. I don't know if Neil would like to answer it, or you would like to answer it. The vaccine in India, same as one in US or West. So maybe you would like to answer that question, either of you.
And
Is it similar, like if the vaccine in India what, similar to one being used here. We know what we are using here, but I would like you to answer it.
So from what I know, the two vaccines in India are the ones being produced by the Serum Institute, which is the AstraZeneca Oxford vaccine, and then the I think it's Covaxin, the Bharat Biotech vaccine. And so both of those, I know the AstraZeneca vaccine, actually, we aren't using here yet. And I know this was recently in the news that we'll be sending the excess shipments there because it hasn't received our emergency use authorization, or it hasn't used, I'm not exactly sure the timeline what the FDA is saying, but we're not going to be using it here anytime soon. And so we are sending some of those shipments to India. It is being used in Europe. And that vaccine is a viral vector vaccine. So they use another they use like a cousin virus, you could kind of say, from a different family to help boost, and they insert the genetic code that you would need to build the immunity to COVID into that virus, and then they give you that as a vaccine. So that's a specific type of vaccine. We use a different type of vaccine here right now. The two vaccines being used are the Pfizer, Moderna, and then Johnson & Johnson. So the first two are mRNA vaccines, and they work in a different process. They directly kind of send some of that genetic information for your body to produce, and then build an immunity. And then the Johnson & Johnson vaccine is also another one of those viral vector vaccines. So like the Serum Institute of India's vaccine. So that way it's similar, even though the Johnson & Johnson is a one shot here. And I believe, I'm not as familiar with AstraZeneca, but I do believe it may be two shots.
Yes, so the AstraZeneca one is used in Europe, as you said. So we have used it in UK as well. It's the same as I think it's called Covishield in India, and so the duration is. I mean, the guidelines kept changing here, of course. But anyway, as long as you have to within 12 weeks, the second dose of the first dose, then you are okay. It has been very successful. The results have been very encouraging for AstraZeneca, which is the Covishield. Covaxin is a local, Indian vaccine which has been produced there, and it has also got very good results. So I think the message from you as well as from everybody here is that take the vaccine, yeah, and that is that is our only way out of the pandemic is the vaccine.
Yeah, and I think there's always some doubts, and a lot of people have been talking about efficacy rates of the vaccines, excuse me, etc. But the best vaccine you can get is the first one you can get. And at this point, which vaccine? The more important part of those efficacy rates are the rates at which they protect against severe and symptomatic disease. So that's more important to look at than, for instance, the Johnson & Johnson, when it had first come out, it was giving an efficacy rate of like 69%. And so people were comparing that to the Moderna, Pfizer, 95%. And that's just testing for COVID. Now, when they do those studies on different time periods, there was like, for instance, the Johnson & Johnson, they did it at a time where there were a lot more people positive for the disease, where they were studying the vaccination, versus Moderna, Pfizer was a little earlier on, where even the rates were lower. So that can influence the efficacy. But we've seen in all the ones that we've used here so far that the rates at which they prevent severe disease is around 90% for all of them. Some of them more, some of them right around 90%. So that's the most important part, because if people, even if you do contract the disease, even if you are getting the disease, you're not getting to the point that it's severe, life-threatening, and that way the system is not being taxed at that point.
Yes. So coming back to your experience as a resident doctor, now one of the very high panic and high stress situation is an ICU. And as I'm sure as a resident in internal medicine, you've had a lot of experience in manning. I mean, even here in UK, we've had foundation doctors and, core trainees manning the ICU because of the shortage of resources at one point. So it is a high risk, very challenging situation. And the problem with the pandemic is the relatives can't visit. And so, that is a heartbreaking situation, and it's heartbreaking for the doctors as well as the relatives. So, do you want to touch upon your experience as a doctor in the ICU, and especially any advice you might have for your colleagues who are working in very stressful conditions in India in ICU, which you yourself found helpful, especially with regard to breaking bad news, because sometimes patients will tragically die. And how would you, it's very stressful, not just for the whole team that is managing the patient. So any experiences on breaking bad news to relatives, what you found helpful, or what you didn't find helpful in that situation?
Yeah, the ICUs have been a very sad place here in that, even the hospital general wards where we've had pretty stringent rules on people coming and visiting, because the last thing you want is that to be one of the spreading events. But that's one of the hardest things that I've seen here, and one of the toughest things that I think we've had to deal with is not being able to be surrounded by your loved ones when you're in that situation. Especially for many of these people, it's the last moments of their life. And so, like, I have been the one that has been there for the last moments of some people's lives, that I know, it feels so heartbreaking to know that, where they should be surrounded by family and friends, in those final moments, it's a great honor and very humbling feeling, to then be there. But it's also very emotionally overloading after. And in the moment, you have to do what you have to do, and you have to be in touch with that. But afterwards, it starts to build up, and you realize that, oh man, I've seen a lot of this. I felt a lot of people be the last person for that. So you feel a lot of loss for sure. And I think for the provider standpoint, having those support systems I mean, I can only speak really personally and from what I've talked to my other colleagues, that being able to talk it out, having someone that feels like a more validative relationship with someone where you can express all those unjudgmentally express all those emotions and kind of let it out is very helpful, because when you're in that scenario, you can't you need to be emotionally there for that patient that's going through that, and then also the family members, because at the other end of their FaceTime video or video visit or whatever, they're feeling the same thing. They all want to be there, and they're not able to. So us, as a providers, being emotionally available there, I know that's very important. That's very tough, because that's another part of the job description that's not.
Absolutely. That's what I was going to say. Actually, it's apart from you being a doctor person that they can reach out, or they kind of scream and shout and give a shout out for you that, oh, I need this, I need that. But apart from that, you're doing a humanitarian work as well. It's not just the doctor. You are there. You are a human being. You have emotions, your feelings. You're seeing a patient in distress, not being able to connect with the family. And we've seen such heartwarming and videos being shared, which is a positive thing. Of course, somebody losing a parent, a close one, a loved one, that's heartbreaking. But then I see these doctors and these nurses taking that role of a family, being there for the patient and connecting them with their loved ones, having them talk to them and say a final goodbye, or say something, so that they feel that they are surrounded by their loved ones. And it was really, really heartwarming. And I see that coming from India as well. And I think that's the support and the human touch we can give to this kind of agony that everybody is going through. And patients getting into the ICU, the moment you hear an ICU kind of a situation, like when it's like you need that desperate help, the family gets panicked, and the patient, person who is going through that, I think there must be a lot of, I wouldn't even call it anxiety. There's a lot of a question mark, that is this it? Is this the final? Whether it's young, old, it's very, very overwhelming for me to even think about it. So I believe we should give a big salute to the medical fraternity, be it doctors, nurses, the attendants, everybody involved, and connecting them with their loved ones, keeping them in touch and keeping them informed, FaceTime and all. India is going through the same phase that we went through last year, and a lot of similarities there, a lot of volunteers helping out, everything. I mean, people are doing whatever is in their capacity to help out, and that's very, very heartwarming. But the situation is bad, so we want to help in whatever way. So Neil, I want to ask you something. At what, like, supposing a person comes to an emergency and is in need of oxygen, is in need of is in distress, basically, whether oxygen level is 90 or 80, is in distress. So at what point do you recommend that the patient should be shifted to an ICU? What is the basic criteria for that?
The basic criteria for ICU, especially in this case, is really how their respiratory status is. So how much effort they're putting into breathing to either maintain those oxygen levels or just maintain their own, what we say, like perfusion to their other organs. So one of the biggest organ that if you see go would be their mental status. And if you know that they're not even able to get enough oxygen to perfuse, basically at this point, and by perfuse, I mean just supply it to the brain even, you're in a very dire situation. Most people that are breathing at a certain rate will not be able to keep up that rate for a long time, especially if other than indications, when they go to the hospital, they get laboratory values, they see their imaging, and they see the extent of damage to the lungs, and they can see the extent of inflammatory response that the body has had. So those all would dictate then how this person goes to the ICU. So honestly, there's an ideal of who should be going to the ICU, and then there's a reality of which ICU beds are there and which staffing is there as well. Really, the biggest thing of the ICU is it's intensive because you have a smaller ratio of nursing staff to the patients, right? You have a more specially trained nursing staff for those patients, and then you have usually a medical team that's kind of given a certain purview for those patients to focus on certain complications, and they're there to resolve those very severe life-threatening complications. And so in the case of COVID, most of those complications arise from breathing. And so anybody who needs assistance with their work of breathing should ideally be in that ICU. Anybody who is not able to maintain a certain amount of oxygen level without a machine that aids in the respiration as well should also be in the ICU. This is all ideally because those people need to be watched and seen when they need to go to the next level. Do they need to be upped from their, we have some of the high flow nasal cannulas, so oxygen machines that really pump a fast amount of oxygen and are able to keep up with that patient's need versus one of the masks that we apply to people that's called non-invasive ventilation. So that will actually help them generate the pressures to be able to breathe, because at a certain point, they'll lose the strength of even having those breathing muscles, whether it's the diaphragm or all the other accessory muscles involved in expanding and contracting the thoracic cavity to help you breathe. So if the patient's at the point that they will tire out with that, then you know that the next step would be either getting them that non-invasive device to help them them keep up with their breathing, or at the final step of the road is then to have an intubation, and that's when we would take over the patient's breathing and put them on a machine. It was very early on in COVID that we noticed that we don't want to jump to that point, because there's so many complications of getting on the breathing machine, and the rates of deaths and complications, especially in COVID patients on the breathing machine, are very high. But so that's the ideal of who should be in the ICU. I think even more important is just who should be in the hospital versus not. Yes. And
so, Neil, just to change
yes,
the topic a bit. So with COVID, with the virus everywhere, doctors are doing a lot of telemedicine. I mean, here, depending on what specialty you are, some are doing it more and some are doing it less. But if in a condition where there's shortage of beds and people are not able to move from one place to another, is there any role for managing COVID patients remotely via whatever FaceTime, Zoom? There's lots of things we can do. So what are the things that can be managed remotely by doctors?
So I'll say here we have the kind of criteria for managing someone in the hospital versus out the hospital. There's no set criteria, but there's certain things that we look as the providers to see that, okay, this person needs to be monitored within the hospital on this versus this person can go home after knowing what their baseline risk is, right? So some of that will be their baseline characteristics and who that patient is, because some people are at higher risk of having these complications than others. So our CDC here has a good list of and I have some good links that I can share or put
Yes,
in just
thank you.
about
Yes,
in general. I'll put them maybe in the chat in a second.
yes.
Yeah, you could put them here so we can share it on Facebook. That'll be great.
Yes.
Yeah.
But they have a good risk over here. In the very beginning, we were just saying anybody with chronic conditions or anybody who is elderly. Now we have some idea that who is probably at the most risk based on the evidence, and then I would say even anecdotally, we would see who's at the highest risk. So the biggest risk factor right now that we can identify is age. So with increasing age, the amount of complications and the amount of monitoring that needs to be done, whether it's monitoring their oxygen levels or if their oxygen levels are low, then monitoring their response to the therapies the initial therapies that we have, like oxygen therapy and giving steroids, that I think that would dictate then who needs to come in and who would feel comfortable with treating outpatient. The other risk factors that then we would look for are also, I personally have seen, and this is backed up with some of the evidence from that CDC chart, that people with diabetes, people with obesity, especially, and people with chronic lung conditions, so if it's asthma, COPD, et cetera, those people are at very high risk and should be preferentially admitted so that they can be monitored and then worked up to see that what their inflammatory levels are, how much oxygen they're requiring, if they're requiring oxygen, and then whether we should start therapy. So, sorry, it's a big loaded question because it'll depend
No, I
on.
know it's right. I'm trying to kind of narrow it down, but it's
Yes.
proving hard because
I
I was
think
thinking from the Indian point of view, because of the shortage of resources we have now. Lot of things which we would normally want to do in hospital, like managing comorbidities and all, unfortunately might have to be done at home. And so there is a timeline before people have been admitted, and then this time after their discharge from hospital. And there doesn't seem to be any clear-cut evidence. I mean, I know you send the CDC guidelines, but this is an out of ordinary situation, isn't it? So with elderly, obviously we have to be very careful, like you said. With comorbidities, we have to be very careful. They need extensive monitoring. Now we are seeing a lot of younger population in India being affected. When you think a person is in their 40s, a bit of fever, what is the worst that can happen? But the worst is actually happening. So whether it's a mutant strain or what's going on, because in the West, it was the same in the US, the younger population were more or less protected. And the morbidity and the mortality was 50 years onwards. And the higher, older you were, the worse it was. So a scenario of a young person who has just got a fever and there's high anxiety. And how would you, kind of reassure the family remotely? What are the things? So we are talking about a younger person, a generally healthy, fit person who has got no comorbidity, or maybe he or she is a bit obese, and that's all it is. And what are the things you would like them to watch out for before the panic button needs to be set in and hospitals have to be looked at? Because what's happening at the moment is that as soon as there's a diagnosis, or the COVID test has come positive, there is panic, and it's very understandable. But because of the shortage of resources, I think we have to control the panic. And I was thinking one of the ways is for people to actually know what are the things we need to monitor in the first few days.
I think that's very true and a good point. So I think for other person at home and starting to feel a symptom. So the symptoms that we know now are common would be either just fever and fatigue, so flu-like symptoms. When you feel just general body aches, fevers, fatigues, then there are respiratory symptoms, cough, sore throat, just general kind of viral when you have a cold. Those symptoms also exist, but then that can also, in more severe cases, you'll see then people may have some shortness of breath, some coughing. In general, people will have exercise intolerance. They won't be able to, you may feel more fatigue with doing your regular activities. Um, and then people are also having these GI symptoms. So they're having symptoms like diarrhea, abdominal pain, and cramping. Those are all things that you should be attuned for. And lastly, I will put this is less people, but seems to be a little more specific, would be the loss of taste, loss of smell, something to be attuned for. It's a very subjective feeling, but something to just be attuned with. So if you're feeling one of those symptoms, my in an ideal scenario, my advice would be that you should be getting tested, and areas that have high rates of testing, especially in the beginning, we're able to know that, okay, what the general population is, and that really helps those public health officials. Now, in India's case right now, when you're going, you should almost just assume, if you're having any one of these symptoms and you're in an area that's undergoing this pandemic currently, you are, especially right now with the shortage of tests, with certain tests now showing negative results, even with people that are so false negative results. At this point, I think the energy expended to go get that test, when you know that they're not there, when it may or may not help. At this point, you should be considering yourself positive. Um, with
And
that,
lot of times, sorry, Neil. Many a times, it's not the first time when you go for a testing, you test positive. I think we've seen many such cases where the first time you went for a test, it didn't show positive, but you have some symptoms. You go the second time, you get the positive test, and then you follow the rules. But I think, as you said, if you have those symptoms and the condition we are living in right now, consider yourself COVID and isolate yourself, follow all precautions, follow all discipline that has been set for this kind of a pandemic. I think, Neil, your voice, something wrong with your yeah, now it's coming through. It's fine.
is it better now?
Yeah, there's a question on Facebook that someone had oxygen sats for 1 week at 99%, and then day 7 it fluctuated between 91 to 95. The person has been having consistently fever 100. Does this deterioration in sats mean cytokine storm or increased viral load? So I don't know, either of you, if you think you can answer the question, please do.
Yeah, I can kind of continue on with basically that outpatient management, because it would apply to this person in particular. So after you've been monitoring for all those symptoms, you feel that you quarantine yourself, then you need to continue to monitor those symptoms, including your fever, and see kind of what track that goes. Right now, that's all that's giving us a clue is that if you're starting to defervesce, if your fever is starting to go away, down, that means your inflammatory response most likely is starting to calm down, and hopefully that's a good sign that you're either clearing this virus, or that the amount of damage being done, kind of, you've gone through the worst of it. But there's not an evidence-based marker saying that, okay, after this many days of fever.
I think the temperature is consistent at 100. It's not going down. That's why. Okay. Yeah.
So that's a sign that they're still having some inflammation. They're still having a response. They're dealing with the virus is attaching to those cells, getting in those cells, replicating, damaging those cells, and most of those cells are usually along that respiratory tract. And so that's why the next step then of monitoring that oxygen levels with the pulse oximeter is very, very helpful, because that a lot of our treatments are dictated, kind of the break point in which we say, okay, you need steroids, remdesivir. These treatments are based on those oxygen levels. And that's just based on the studies that were done showing that the patients that were that severe, that the oxygen was going down, they benefited from that. So now what level of oxygen that will benefit from these, that's also a point of contention. And generally, we say the normal levels are above 94%. It doesn't mean 100%. It means anything from 94 to 100 is within that normal range. The lower end of that would be from 90 to 94%. So that's when you don't necessarily, not everyone will require oxygen at that point. If it's below 90%, they need to be in a hospital, they need to be receiving oxygen, and they need to be starting steroids. So that's kind of the initial breakpoint. In this particular case, you have someone whose oxygen is going down to levels that are slightly below normal. So that's in that in between 90 to 94 range. Given the shortages there, I mean, the things that you can do at home right now are continue to monitor those symptoms, continue to record. So that's the fever, their oxygen levels. And then the one thing that we have seen success is called proning. And we can do this. It's a pretty simple exercise that you can do. And there's some good videos I should send to
Yes.
showing how you can do this awake proning. And this is a maneuver we do within the ICU as well. But you can do it awake, you can do it at home. And this is just to kind of open up certain areas of your lungs. So in this particular case, for this person here, I would say you need to continue monitoring those oxygen levels. If they're really dipping below, they ideally right now they need to go to a hospital. I know that's not available to many people. And so what they can do to help increase those oxygen levels are some either just deep breathing techniques to recruit more of their kind of the posterior area of their lungs. And for a lot of people that are resting at home, because of the symptoms of body aches, fatigue, or lying down and resting, the proning exercises are very helpful. So that would involve when you are resting. I mean, you should be as much as you can walking around during the day, still staying active, just to keep your body from deconditioning and not being able to deal with the virus worse. So proning would be then laying on your stomach, right? And when you're resting, spending a good at minimum 1 to 2 hours as you rest on your stomach. You can also spend it on your left side, your right side. In the ICUs, we basically rotate people, and that's based on staffing to see if we do an 8-hour to 16-hour, but those people are confined to a bed. So that's what we're trying to do, is put them on either their back and then switch them to their belly, so that the posterior area of their lungs that has been kind of sitting on with the weight of gravity are able to open up. And a lot of people have seen improvement in their oxygen levels, and kind of keeps them away from that that level of needing respiratory support. So that's one thing you can do at home, especially for this case that you're describing here. Again, ideally everyone should be going and getting these monitored in a hospital and then initiating treatment. But this is the kind of what I can think of at this point, given that scenario.
Yes. And the temperature obviously is not going to go straight away. It will be fluctuating. The temperature is really an inflammatory marker of inflammation. And until the whole inflammation goes, the temperature is going to stay, isn't it? So the red flags would really be if the SATs go below 90 at some point, and they don't come up after proning or walking around, and the temperature increases further, and there is breathlessness. I think breathlessness is the main thing. Would you agree, Neil? That is going to be a red flag in all cases. Once the breathlessness sets in, that's the time to worry.
Yes, and I think breathlessness, especially, you will feel, some people will feel breathlessness with doing activities. So on exertion, that the normal activities, if you were able to go for a walk and suddenly you're feeling that, oh, I feel very tired after a walk and maybe a little short of breath, versus the other end of that spectrum is I'm sitting down and I feel like I can't catch my breath. I can't finish sentences. So that's, I'm even talking for me is exerting too much energy, and I'm starting to feel that my rate of breathing is going up just to keep up with that minimum amount of it. That's a very worrying sign. And that's when, along with the oxygen levels, those are two of our biggest breakpoints in saying, like, okay, this person needs to be treated with everything that we have at this point, versus this person can be just monitored.
I think there are a couple of questions on Facebook, and I am not sure if we can answer them all right now, but as we say every day that we are going to get them addressed as soon as possible. We'll have Dr. Kaul or Dr. Bima Schreiner address those questions and your concerns. Because I see other guests here on Zoom. If they would like to ask anything, please ask away. I didn't hear anything from them, but yeah, Shafalika, if you have anything, just
joining on Zoom. So thank you, Neil. That was very helpful because we've had specialists over the last 3 days. But like I said, you are our foot soldier, and and who has also had COVID, and you have come to it, and that's a very positive message. You were at the front line, you got COVID, and you came out at the other end. In spite of everything else that was going on around you. So that's a very, very helpful message from you, Neil. Now, just we are trying to finish today's session. Do you so apart from you being a doctor, you're a youngster, and so would you want to comment, because in Houston, that's where you live, isn't it, in Texas? As everywhere else, there was quite a bit of panic about medical supplies as well. The hand sanitizers we couldn't find. I mean, it was the same here. Gels, everything just flew off the shelves. And and as medics and as doctors, you must have gone to superstores and said, "Oh, what is going on here?" So, do you want to comment a bit on that as well? Because the same scenario is happening in India now. Things are just flying off the shelves. You can't, even simple things, you can't find them now.
Yeah, and I think this kind of like hoarding mentality is not helpful. These are just these aren't professional or any
Yes.
opinions, but just
yeah, we
personal
understand
opinions.
that.
What I saw is that that hoarding mentality is never very helpful, because they're when the hospitals start to run out, that's when it's very severe.
Yeah.
When the hospitals are not getting enough masks or PPE and people are trying to hoard them or buy them in bulk, that's dangerous, because honestly, you're not doing a favor for yourself. Because if you or your loved ones then and need to end up in the hospital, doesn't matter how many masks you have stocked up at home. The fact that they're going to the hospital and they don't have enough equipment, that means one of those providers isn't going to risk, isn't going to go in there without a mask if he doesn't have them, right? And we need to look out for our safety first, because we're the ones going to treat everyone. And so you really need, like, the hospitals and the providers and those frontline workers, they need that equipment. And so hoarding that to yourself, I think, does yourself a disservice, because you're eating away at that system that you may need at some point. And the last thing you want is, if you need that system, it doesn't have the preparation for you. And that's unfortunately the reality that we went through that. India, I know, is going through that. And so I think those, and then for just people that are not being affected as much by this, I think we've seen, I mean, how that false sense of security you can get. And I know everyone in India must be feeling this in some sense,
Yes.
in some fashion, that you can't let that, you can't get complacent like that. You have to always be on your guard and considering this. And that if it's not something entirely necessary, you have to really weigh those risks and benefits of, am I going to have this kind of big function now? Do I have to have it now? Can I have they're very difficult personal decisions for people to make, but you need to kind of be, hope for the best, prepare for the worst. So your worst preparation is that if I have this shadi coming up, or it's one example that, like, maybe we need to scale down on those things, because who knows, if I plan for this wedding on this date, a lot of people that were planning for these dates, I mean, when they felt that things were opening up, now they're faced with the decision that we might need to postpone, cancel. And looking within yourself and saying, okay, what's important to me? How can I get that done in a fashion that is safe, right? If it's a wedding, can we just get a ceremony over with and not have postpone all the big celebrations and all that until after, if that's what's important to you, etc., or postpone the entire thing. Same thing with just meeting up, partying, socializing. Those are all very important. But then saying that, okay, the risk of that, especially in India right now, is very, very high. The risk of that here is even high.
It's high
But
everywhere. And
yeah, it's
India
high
is,
everywhere. There's a safe way to do it, and you have to you basically just have to be cognizant of what's going on around you, what the recommendations are for your authorities, following those, and making a conscious effort every day to keep up. As things get better, you will get kind of advice from above that these things are now evidence-based, hopefully okay to participate in. So things will get better with these vaccination rates, etc. But
yes,
you
and
just have to be
that's good.
cognizant of that. You can't let that guard go down and say that because I feel better and I feel that things are better, now I'm going to open up. It's really what the curves, what the data is showing. Okay, then I can modulate my behavior based on that.
Yes.
And to
And
add
it's
to your
not
point,
about you, it's about everyone else as well. People around you. You might be feeling better, but everybody else you have to look after. So we are just about to finish, and Nidhi has an announcement before we finish. But
yes,
thank you, Neil. It has been wonderful to have you. You know, trainees, resident doctors. I think without them, the health service in the whole world would collapse. And that's the same in India as well. You know, nurses.
to add to Neil's point that we were last year, we had the same scarcity of essential supplies in terms of masks and sanitizers. I think each one of us made sanitizers at home. We made masks, and not only for ourselves, but for the communities, for healthcare workers. We supplied it to hospitals. Not me personally, what I mean, communities did that. And that's a great resource as well. Each one of us are trying to help, whether we are here or we are in India. Our basic aim is to support our people back home, and that we are going to do, and we're doing it at the moment as well. So we wish each one of you safe and healthy life, but at the same time do maintain that social distancing, wear masks, don't go to public places. Weddings and birthday parties can wait for now. We just need to think about getting rid of the pandemic as such. So this Saturday, I think I remember Dr. Surinder Kaur making an announcement earlier also. We'll have Professor David Hilmers from Baylor College of Medicine as a guest. It'll be a very, very informative session. So I would request everybody to join in that day. And being a Saturday, it's going to be a little relaxed. We can have a longer session. He can answer your questions, as many as you have, and concerns as well. So Neil, thank you so much for being here with us. Dr. Neil, I'm sorry, it just.
No, thank you guys. So I'm very humbled to be on here because you have some big names, not just in our community, but who are connected with our community, or even from institutions here in Houston, like you said, these faculty that are coming on. So I'm a very small fish compared to all of that, but I'm very thankful that
You are not a small fish.
You are
Like
not.
I said, the health system would collapse without residents.
If we didn't have
trainees. So yeah. So thank you, Neil, for coming. You are a community worker at heart, and that's one of the reasons you are here.
You're here today.
As a community, we are looking up to our doctors and our children to guide us through this. And for that, we thank you on behalf of the British Medical Pandit Diaspora. So thank you all.
Thank you, dear. Thank you, Dr. Neil. Bye-bye.
Namaskar.
See you. Namaskar.